much. Before proceeding into those environmental factors, particularly in Rwanda, it's better to understand first what allergy means and what airway allergy means. When you say allergy, it is overactivity of our immune system to a usually harmful substance called allergen. These allergens, when they are ingested, inhaled, or were injected, or when they are touched, they can cause allergies. So based on the specific organs involved, it can cause like allergic food disease, or allergy of the skin, or allergy of the airway, or allergy to drugs. So when we say airway allergy, we divide it into upper airway and lower airway allergies. So when we say upper airway allergy, typically it's allergic rhinitis. When we say lower airway allergy, it is asthma. So this airway allergy is due to inhalation of these allergens introduced to our body, then the immune system overacts so that there is airway constriction, airway edema leading to manifestations. So when we came to the risk factors, we need to understand why these allergies happen. So when you say allergy, the causes are multifactorial. So there is two important factors. One is the genetic, the other is environment. So when you say genetic, there is genetic susceptibility. So there are many genes loci in the body that can predispose for allergen, and an individual who is genetically susceptible can have exposure to environmental allergens so that it can manifest as allergic airway disease. So when you came to environmental factors, which are prevalent worldwide here in Rwanda and other developing countries, we see allergy is becoming more common because of urbanization. So the most important allergens, especially the inhalational allergens, are divided into outdoor and indoor. So the indoor allergens, there are four important allergens that's commonly called airway allergen. One is pollen. The pollen shedding from trees and grasses, usually seasonal one, more common in the spring, summer, so they can cause allergy to airways. Second is dust mites. The dust mites are small microbic insects that usually reside in our bed, our sofa, carpets. They are harmless, they don't bite humans, but they are the cause of allergies. The other cause is like mold, fungal molds. They can grow in wet areas in our home, like in carpets or sinks or showers, so they can be cause of allergen. Other insects like cockroaches are basically known to cause also inhalational allergy as a cause. So these are important allergens that cause airways overactivity and leading to manifestation. When it comes to outdoor allergies, mainly the pollens go outside from trees during the shedding season, the flowering season. The pollen are very important cause of allergens, and the others are smokes released from traffic and factories can predispose for allergy sensitization, and any smoke in a home or children exposed to cigarette smoke at home can be predisposed to also this allergen. So these allergens are common worldwide. Here also in Rwanda, there are some studies showing more allergies are encountered in urban cities than rural areas. So this is due to this is so-called hygiene hypothesis. What does it mean? It emphasizes the prevalence of allergy in urbanized population in rural areas. So in urban areas, the more clean we are not exposed to the natural microbes, we're not exposed to natural allergens, whereas there are lots of dust and air pollution that can cause to allergies, because natural exposure from childhood to natural allergens and microbes protect airway allergen. So the more urbanization, the risk of allergy increase, so now it's becoming more common. So these are important environmental factors which is very important to identify and important for the prevention of this allergy in airways. Yeah, we have observed there are literatures also showing increase in allergen In the previous years, it was well known more in developed countries, but now it's increasing more in developing countries. Also, studies in sub-Saharan Africa, the risk of airway allergies increasing, basically asthma and allergic rhinitis are increasing. We're also seeing cases increasing in our outpatient department. Most common presenting airway condition is asthma and allergic rhinitis. So before going to prevention, we need to understand also what are the symptoms, what are the symptoms that the family should notice. So when it comes to symptoms, these two diseases, allergic rhinitis and pediatric asthma, they can occur together in around 40% of the cases. But we need to discuss them separately. So in allergic rhinitis means inflammation of the nasal mucosa, not merely the nasal mucosa, also other adjacent structures like the eyes, the throat, the oral cavity, the ears, and the sinus, so that can result in frequent sneezing and can result in blocked nose most of the time. It's persistent weeks and months. We call it nasal stuffiness or nasal congestion. Irritation and itching, intense itching. Usually kids try to rub their nose like upward like this. We call it allergic salute, and due to this frequent rubbing, there might be a horizontal crease on the nose. So sometimes you can see some black circles underneath of the eyes. This frequent exposure can also lead to enlargement of the nasal mucosa. Inside it, there is called nasal travinus, bony structures covered by the mucosa that are very important to filter air, but allergies can enlarge them and cause obstruction. And sometimes this frequent exposure to allergen can result in adenoid hypertrophy. These adenoids are lymphoid tissues at the back of the nose, can cause enlargement. So this enlargement can block the nose, can cause obstruction during sleeping, called obstructive sleep apnea, and can lead to problem in the chest and the heart and lung standing. But also additional symptoms of allergic rhinitis, they do have tearing and redness of the conjunctiva of the eye, and they usually rub the eyes, and they have headache due to sinusitis, throat pain, and they have dry cough, they have ear pain, both ears they feel ear pain. So these are the symptoms of nasal irritation, nasal inflammation, and adjacent structures. This is, we call it basically upper airway allergic symptoms. So when it comes to asthma, it's a lower airway symptom. So kids usually present with episodic or recurrent cause of coughing, wheezing, abnormal breath sound, which is whistling expiratory breath sound that occur due to narrowed lower airway. So they tend to have wheezing, which is episodic, the difficulty of breathing, the feeling of chest tightness. These symptoms usually occur during more likely of the night, and during the day when they do play or exercise, manifestation can occur. So these symptoms of upper airway and lower airway allergies should be noticed by the parents to seek their advice. Good. So the management, initially we need to identify or diagnose the allergy first before proceeding to the management, and identify the possible risk factors that can be identified so that they can be avoided. So when it comes to diagnosis, we take a thorough history about the symptoms of allergies, the time of occurrence in the day or time of occurrence in the year, if there is seasonal, what aggravates the situation if the parents notice, or what relieves the situation. So these are important symptom characterization, especially in allergic rhinitis. There might be a brief episode of rhinitis or rhinosinusitis from viral infections, which is not really allergic. So to differentiate this, for example, in infectious rhinitis, there is usually fever, and the nasal discharge is initially clear, followed by a thick mucoid, yellowish and green, while in allergic rhinitis, a clear discharge. and itching more intense in allergic rhinitis, and infectious rhinitis usually lasts within 7 to 10 days, but in allergic rhinitis it takes weeks and months. Unless treated, symptoms can persist. So this is important differentiation between a simple infectious flu-like rhinitis and allergic rhinitis. And the other thing, when it comes to asthma, also this is the characterization of the onset of the symptoms, how severe the wheezing, the cough, any difficulty of breathing at night. These are also important characterization. In addition, we do some tests or investigations to diagnose the cause, especially in upper airway allergy. Usually diagnosis made by history and physical examination, but we might do tests to identify what allergy causes the disease or what are the triggers in susceptible individuals. While in asthma, we have tests like X-ray, just X-ray, and like the pulmonary function tests, we call it spirometry for those more than 6 years to diagnose really is it asthma or not. And another important test we need to do is what triggers the asthma, what triggers the allergic rhinitis. So this can be done by two important tests. One is a skin prick test. What skin prick test is, we introduce this mentioned allergen extracts in the skin of the child or adult, the volar aspect of the hand or the back. So we allow that to enter to the body by scratch or a prick, so that we know which allergy cause reaction. So if there is a reaction to specific allergen, the best management to avoid that allergen. So this skin prick test is very important. It can be done here. The second is blood test. So some labs can do allergic specific immunoglobulins, so that we can identify which specific allergen triggers the symptoms. These are important tests for prevention and the management of the allergy. So when we come to the management of the allergy before going to prevention, so we need to see one by one, because the management is somewhat different. In allergic rhinitis, there are 4 pillars of management basically. First is avoiding triggers. So this allergic rhinitis, usually the children, they don't outgrow from the symptoms. The symptoms can get better with age increasing, and only nearly 20% of them they do in remission. So the best thing is avoiding the triggers. So when you say avoiding the triggers, those important allergens we mentioned, the dust mites. So the dust mites, as we have said, where they live in our home. So how to prevent dust mites? To avoid dust mites, we need to cover the pillows, the matters of our bed with dust mite impermeable cover. Basically, in adults we use plastic covers, but in kids there is risk of suffocation, so we use the tightly woven garments to use cover the pillow and the matters, which is very important. And minimize carpets in the home, in the bed, and avoid stuffed toys in child's bedroom, which is very important. They can harbor a lot of dust mites when they are kept inside. This is an important prevention modality for dust mites. The second is common allergies, another animal dander. When you say animal dander, this is a shed of dead cells and the scales from pets, cats and dogs basically. So pets, cats living in our home can be a cause of allergy. Therefore, the dander from them, just like a dandruff in the hair. So to avoid this, if it's known as a cause of allergy, the best is to avoid contact with them. The best is removing these pets from home. If not possible, at least we need to remove from the kids' pets, because they are cause of allergies. And other measures like washing the pets properly, that can decrease also the dander. That other measures that for those they couldn't remove from their home. Other allergens, the molds. Molds, they grow in damp areas in the home, even the home. So try to dry the carpets and fixing leaked sinks and drying the showers and the sinks and avoiding all the books in the house, that ventilating the house and decreasing the humidity, controlling the humidity, which is very important to prevent mold in the house. Other causes, pollen. Pollen usually is a cause of allergy in the outdoor, so it's more of seasonal. So closing the doors during that season, not to allow pollens coming in contact with the kid, and also at school, if they are known to be allergic to pollens, closing the windows, very important. In the cars, also closing cars, because there are seasons where the pollen can be high from grass and trees. So these are important to avoid triggers. The other thing is in asthma inhalation, like smoke in the house, be it cigarette smoking from older adults, or other smoke from cooking, that should be avoided. So the home should be smoke-free. And the other thing, maybe the air pollution, another important factor. So minimizing air pollution is a factor that reduces the allergic rhinitis as well as maybe asthma. The second pillar of management in allergic rhinitis is drugs. We use drugs, control with drugs. So we have several types of drugs we are available in Rwanda too. First is so-called oral drugs, antihistamines. So antihistamines are prescribed, also they are over the counter, but better to be evaluated by physician and prescribed by physician. There are two types of antihistamines. One is sedating, the other non-sedating. On the sedating antihistamines, they call more sleepy or sedate the child. These are called first generation antihistamines. The second generation antihistamines are non-sedating, which are more preferred because less sedative effect and more effective also as the management of allergic rhinitis. So from the group which are available here, sedating antihistamine like chlorpheniramine, promethazine, and others in combination with others also available. The non-sedating antihistamines we usually use like loratadine with different brands, loratadine, cetirizine. These are typical prototypic drugs we use for allergic rhinitis as oral medications. The other, the cornerstone of management is nasal steroids or sprays. So for moderate to severe allergies, antihistamines alone cannot treat allergic rhinitis. So we need to use to control the symptom. And to decrease inflammation in nasal airways and adjacent structures, we need to use nasal steroids. So worldwide, there are around 6 steroids approved for use in children. Mainly, we use them above 2 years. Here in Rwanda, we have commonly mometasone. With different brands, we use mometasone. So based on the age, above 2 years, based on physician prescription and duration, it has to be used properly to avoid side effect, even though the side effect is minimal because the steroid in it is low. For those less than 2 years, for young, we don't use steroid most of the time, but we can use saline, normal saline or salt waters, irrigation of the nose as frequent as possible to alleviate symptoms. So the other pillar of management is allergic immunotherapy, which is not worldwide, but if the symptoms are not able to be controlled by all these measures, we call it allergic immunotherapy. We introduce introduction of a small amount of allergens through time into the body, so that they can cause decrease in sensitization. So this is one promising therapy, especially maybe effective for severe ones, but not available in every setups. The other treatment, oral treatments like we use also like antihistamines, we call it leukotriene receptor antagonists also can be used. So this prescription drugs, this drug should be at least prescribed or should be ordered after they are diagnosed to have allergic rhinitis. And the best thing is to identify the trigger and avoid the trigger. When we come to asthma, and avoiding allergens asthma, it works also for asthma and like allergic rhinitis. But basically in asthma management, there are pillars, or there are 4 categories of asthma management. The first thing is we need to categorize how severe the asthma is, usually made by a physician in the hospital setting. The second is asthma education of the parents. And the third is avoiding triggers, which is almost the same as avoiding triggers in allergic rhinitis. And the fourth is asthma pharmacotherapy or drug management. So when you come to education in asthma, so educating to have a regular follow-up and to avoid as much as possible the triggers of asthma. So in addition, asthma can be, in addition to the triggers that we mentioned, like dermatitis, pollen, mole, and animal dandruff, viral infection is a common cause of asthma exacerbation. So the viral infection can be reduced by, during the flu season, with proper hand washing with water and soap, like we did it in COVID season. And whenever there's a family member having flu, he can protect kids by wearing a mask. And also this can be applied at school, so that these susceptible children with asthma will not be exposed to allergens and exacerbations, so that we can prevent them exposing to drugs and hospitalization. And the other education in families, in addition to avoiding triggers, is the asthma pharmacotherapy techniques, how to take medicines, very important. We might touch with the pharmacotherapy. So the third one that we mentioned is avoiding triggers and treating comorbidities in asthma. So triggers are, like I mentioned, the same as allergic rhinitis. In addition, the viral infections are very important exacerbations, and smoke in home and air pollution, very important factor for asthma exacerbation in children. So this has to be also avoided. It's an important lesson for the parents. When it comes to asthma pharmacotherapy, we divide asthma into 2 categories, basically in basic terms. One is the asthma exacerbation, the other is chronic asthma. When you say asthma exacerbation, children could have acute attack of asthma with wheezing, chest tightness, difficulty of breathing, so that they need to be treated in the health setting. So during asthma exacerbation, we usually classify them based on severity, but they need to visit the setting, or if they don't have the medication, they can start at home. So at the health setup in Rwanda, what commonly we use is bronchodilators or rescue medications or asthma attack relievers. So these bronchodilators, short-acting beta agonists, Ventolin most known, or salbutamol we call it, we use in a form of nebulization or inhalation in the hospital setting. That inhalation can be also continued as outpatient at home. In addition, we give also steroids systematically, like oral steroids like prednisolone, dexamethasone, or if it is severe one, we use intravenous steroids, hydrocortisone, methylprednisolone, or dexamethasone to relieve the acute symptoms. This is called asthma exacerbation. The other therapy is chronic asthma. In chronic asthma, usually, when asthma persists, like occurrence of symptoms more than 2 days per week, and with nighttime awakening more than once or twice a month, the risk of persistence is high, so we need to control them. So this control medication are called long-term controllers. So these controllers, there are different categories. When I mentioned from the most commonly used and less commonly used, or based on the severity, most commonly the cornerstone of management in persistent asthma is steroid inhalations. So steroids, again, same steroid inhalations, more than 6 national steroids approved to use in children. Based on the age of them, the dose can be adjusted. The most commonly used steroid here is piclomethasone, budesonide, fluticasone. These are the steroids that we use. Sometimes there are combinations with steroid and beta agonists, but we use steroid as long-term management. But it needs intensive education of parents, and we need to have action plan. The physician, the parents sit and prepare action plan for asthma management. Other therapies of asthma, controlled by this. Sometimes we add other therapies like leukotriene modifiers. Leukotrienes are inflammatory markers that cause constriction, bronchoconstriction, and symptoms of asthma. Montelukast, there are available drugs that we can add. We add them, and also other therapies can be added if the asthma is not controlled. But the most important treatment in chronic asthma is inhalational steroids with less side effects. So these steroids, when used, proper technique should be educated for the parents. Usually at home we use this national steroid with spacers for kids. So the proper technique to administer and to decrease the side effects. Usually side effects are local one, like oral thrush, because it affects oral mucosa. Oral fungal infection common, so gargle the mouth after use, a very important one. A child on chronic asthma management or controller, if has exacerbation, always we need to give quick reliever like Ventolin at home, and then they should bring their child to the hospital for further assessment and other medications. Then after treatment, they can go back to the normal control medication. This is the highlights of management of allergic rhinitis asthma. These are basically the upper and lower airway allergies. Probably. So the importance of managing allergies because of the comorbidities and complications. So if not treated properly, both asthma and allergic rhinitis, they can have lack of sleeping. They could have also fatigue. They can miss school. So it can lead to abnormality in the chest. So it can cause morbidity significantly, sometimes cause, especially asthma, mortality. So in addition to management, controlling the allergy, very important. As I have said already, once there is genetic susceptibility, the most important thing is identifying the allergen and decrease those allergens. So as a population or an individual, most important, if these symptoms are there, brings them to hospitals. Try to identify the triggers that we mentioned based on a skin test or prick test or allergic blood test, so that avoid that trigger as individual, and adherence to control medication, which is very important. But as a community education, these 4 important indoor allergens should apply to all the community. The pollen, the animal dander, the dust mites, cockroaches, these molds, very important indoor allergens which applies for all household communities, or they need to be prevented the way that I mentioned before. The other thing, probably the smoke from factories, the air pollution from vehicles we use can cause pollution and cause airway disease. So the presence of this smoke sensitization can lead to more allergic condition, allergic airways. So as much as possible, maybe in long term, reducing this air pollution, controlling the air pollution as a community, as public, are very important measures to control allergy. Otherwise, as more urbanization, we tend to have more cases of allergic disease. The more commonly is respiratory allergies, because these inhalational allergens come in contact with respiratory tract.